Hello students, welcome to this session. In this session, we are going to have a quick rapid revision of abdomen, pelvis and perineum. The uterus has a fundus, body and cervix. Fundus is that part of the uterus that we see above the opening of the uterine tube. And you can see that there is no cavity within the fundus. What about the body? It has a uterine cavity and it extends from the fundus above to this narrow part that you see here between the body and the cervix. It is called the isthmus. It corresponds to the internal os, the junction of the cavity of the cervix with the cavity of the body of the uterus, right? The internal os, the junction between the cervical canal and the uterine cavity. And the cervix is that part of the uterus that lies below the isthmus. This is the vagina. The attachment of the vaginal wall, it divides the cervix into a supravaginal part and a vaginal part, right? The fundus, body and the cervix. What is the angle of antiversion and antiflexion? Antiversion, yes, is the forward bending that you see there between the cervix and the vagina. So this is the axis of the vagina and this is the axis of the cervix. The angle between the two, it is called the angle of antiversion and it measures 90 degrees. It is maintained by the forward pull of the fundus of the uterus by the round ligament and the backward pull, yes, at the cervix by the uterosacral ligaments and also the intrinsic growth of the uterine musculature. This angle of antiversion is important. Okay, because the axis of the vagina and the axis of the cervix, they are in different plane. Imagine if this angle of antiversion is not that, then the cervix with the uterus, right, it can drop into the vagina leading to prolapse. And then antiflexion is nothing but the angle between the, yes, the body of the uterus and the cervix at the isthmus. It corresponds to 125 degrees, right? So this angle of antiflexion at the isthmus, it is the junction between the upper mobile part and the lower fixed part. The uterus, it presents an anterior surface and a posterior surface. Anteriorly, this is the bladder, right? It is separated from the bladder by the uterovesical pouch. And posteriorly, yes, we can see the rectum, this is the uterus, this is the recto-uterine pouch, the pouch of Douglas. We have seen it in detail, right, in peritoneal cavity. Now, the lateral borders of the uterus, they give attachment to the broad ligament. Yes, broad fold of peritoneum that attaches the lateral wall of the uterus to the lateral pelvic wall. And along the lateral border, yes, within the broad ligament, we can see the uterine artery. The course of the uterine artery is tortuous so that it allows expansion of the uterus. Over here, can you appreciate the tortuous uterine vessels, right? And remember, the uterine artery is a branch of internal iliac artery. Anterior division of internal iliac artery, right? Now, coming to the relations at the lateral angle of the uterus, there are three important structures. This image that you see here, here is the urinary bladder, this is the uterus, and here is the rectum, right? So, this is anterior and this is posterior, okay? Over here, you see the attachment of the fallopian tube, right? In front and below, this is the round ligament of uterus, right? The round ligament of the uterus, remember, it passes through the deep inguinal ring, inguinal canal, and then exits out of the superficial inguinal ring to attach to the labium majus, right? And here, behind and below the uterine tube, this is the ligament of ovary. Can you make out the ovary here? So this is the ligament of ovary. So these are the three structures attached at the lateral angle of the uterus. Now coming to the important relations to the supravaginal part of the cervix, the lateral relations. So here, can you make out the vaginal wall, right? And this is going to be the supravaginal part of the cervix, just few centimeters lateral to it, 2.5 centimeter lateral to it. You can see the ureter, right? This ureter, it is crossed by the uterine artery. The uterine artery, it crosses anterior to the ureter from lateral to medial, right? This ureter, it passes below the broad ligament, okay, to reach the bladder. And the uterine artery, it crosses the ureter from lateral to medial to enter within the broad ligament. And remember, we saw a tortuous course along the lateral border of the uterus, right? Okay, and here, remember, we saw the attachment of the broad ligament, isn't it? So, yes, it is related to the base of the broad ligament. And then, what is this important ligament that you see here? The Mackenrodt's ligament. Which connects the cervico-vaginal junction to the lateral pelvic wall, isn't it? It is one of the strongest ligaments and it is responsible for keeping the cervix in the median position. And over there, this is the paracervical lymph node. So the important relations, the lateral relations of the supravaginal part of the cervix includes the ureter, the crossing of the uterine artery anterior to the ureter from lateral to medial, and then the lower part of the broad ligament, the attachment of the Mackenrodt's ligament, and the paracervical lymph node. So here, can you appreciate? So this is the cervix here. This is the urinary bladder, the ureter. Can you appreciate the uterine artery? Yes, crossing the ureter from lateral to medial. This relation is very, very important during any surgery over the uterus, hysterectomy, and when we ligate the uterine artery, care should be taken not to injure the ureter. Now come on, let's learn the ligaments of cervix. So where is the cervix here? This is the cervix and this is the sacrum. So this is posterior and this is pubis. So this is going to be anterior. This ligament you see here from the pubis to the cervix, pubocervical ligament, a pair of pubocervical ligament. And over here, this fan-shaped fibromuscular tissue connecting the cervix to the lateral pelvic wall, the fascia over the levator ani, right? This is the Mackenrott's ligament, the transverse cervical ligament or the cardinal ligament of the uterus. Why is it important? I told you, it keeps the cervix in the midline. So if there's injury to this ligament, then the uterus can descend into the vagina, leading to prolapse. This ligament from the cervico-vaginal junction to the sacrum, opposite the third sacral vertebra, it is called the uterosacral ligament, right? This uterosacral ligament, it pulls the cervix backward to counteract the forward pull of the round ligament. and maintains the angle of antiversion and antiflexion. The blood supply of uterus, of course, it's very important, and we know it's from the uterine artery, branch of the anterior division of internal iliac artery, and also from the ovarian artery that arises from the abdominal aorta, isn't it? So if you see here, the uterine artery, it gives branches, right? These branches are called coronary or arcuate arteries. These coronary or arcuate arteries, you can see them running transversely both on the anterior surface and the posterior surface of the uterus. These arteries of the opposite side, they anastomose across the midline. Right. And from this coronary and arcuate artery, we get the radial arteries. These radial arteries, you can see them piercing the myometrium, and over the middle layer of the myometrium, they form the stratum vasculare. Okay? And from the stratum vasculare, we get two types of branches. The basal arteries and the spiral arteries. The basal arteries, they supply the stratum basale, the basal zone of the endometrium, which doesn't undergo any changes during menstruation. The spiral arteries, the spiral arterioles, they go upwards to supply the functional zone of the endometrium that is shed during menstruation. The lymphatic drainage of uterus and cervix, yes, it is very important. Okay, here. The lymphatics from the fundus and the upper part of the body, they reach the pre and para-aortic group of lymph nodes. Right. And some of the lymphatics from the lateral angle of the uterus, they follow the round ligament to reach the superficial inguinal lymph nodes. And the lymphatics from the lower part of the body, yes, they reach the external iliac nodes. The lymphatics from the cervix, right, they can reach the obturata nodes, the external iliac nodes, the internal iliac nodes, and some of them from the posterior aspect, they can reach the sacral nodes. Coming to the broad ligament of the uterus. This broad ligament, as I told you, it is a broad fold of peritoneum, right, that anchors the lateral border of the uterus to the lateral pelvic wall. And you know what? It consists of an anterior layer and posterior layer. What are the parts of this broad ligament? It will have a antero-inferior surface. So here you can make out the uterine tube. This is the ligament of ovary. So we are seeing it from the posterior aspect, right? Okay. So what you're seeing here is the postero-superior surface in this image. The antero-inferior surface will be related to the bladder in the midline and paravesical fossa on the lateral sides of the bladder. The postero-superior surface that you see here will give attachment to the ovary. And this part which gives attachment to the ovary, this is called Mesoovarium. right? Two surfaces and then two borders. This is the upper border of the broad ligament. So over the upper border, we can see that the anterior layer is reflected as the posterior layer, and the medial 3/4 of this upper border, it's going to be related to the uterine tube, and the lateral 1/4 over here, that is related to suspensory ligament of ovary. The upper border. The lower border of the broad ligament that you see here, yes, that will be resting over the pelvic diaphragm. And here what happens, the anterior and the posterior layer, they separate from each other in the lower border. Okay. And just now we saw, right, over the lower border, the related structures, the ureter and the crossing of the uterine artery. And yes, the medial border of the broad ligament, that is attached to the lateral margin of the uterus, and we can see the tortuous uterine vessels there. The lateral border of the broad ligament will be anchored to the lateral pelvic wall. Over here, can you appreciate the presence of the ureter in the lower border? What are the subdivisions of this broad ligament? This part that lies between the uterine tube and the ovary and ligament of ovary, it is called the Mesosalpinx, right? And this part that lies between the ligament of ovary, the ovary above, to the base of the broad ligament, this is Mesometrium. And over here I told, right, the postero-superior surface extension of the broad ligament to give attachment to the ovary, that is called Mesoovarium. And this part over here, connecting the uterine tube and the ovary to the pelvic brim, this is the suspensory ligament of ovary. Okay. So, what are the four subdivisions of this broad ligament? Mesosalpinx, Mesometrium, Mesovarium, and the suspensory ligament of ovary. So, this part that we see here between the uterine tube above and the ligament of ovary is the Mesosalpinx. You know what it contains? Remember, our uterine artery was coming like this, and the ovarian artery, the anastomosis between the uterine and the ovarian vessels, right? And then, yes, the Mesosalpinx, it has the uterine tube, the anastomosis between the uterine and the ovarian vessels, and also over here, yes, the tubules of epophoron, parophoron, and the duct of the epophoron. Okay, so these are the contents of Mesosalpinx. This part of the broad ligament that extends between the ovary and the ligament of ovary above to the base of the broad ligament, it is called as Mesometrium. Yes, this has the tortuous uterine vessels. Okay, what is Mesoovarium? It is derived from the posterior layer of the broad ligament, and it gives attachment to the ovary, isn't it? It transmits the ovarian vessels and the nerves to the ovary. Lastly, this is the suspensory ligament of ovary. It connects the ovary and the uterine tube to the pelvic brim. It passes across the external iliac vessels. Okay, it transmits the ovarian vessels and nerves. It is also called the infundibulopelvic ligament. Now, again, this is very important. What are the contents of this broad ligament? This broad ligament, it has the uterine tube, the proximal part of the round ligament, the ligament of ovary. What are the vessels you get to see here? Yes, the ovarian vessels, the uterine vessels, and then tubules and duct of the epophoron and tubules of the parophoron. right? Lymphatics, nerves, and accessory suprarenal tissue. These are the contents of the broad ligament. The supports of uterus, again, very important, right? To prevent uterine prolapse. The main role is by the muscles and ligaments. So, muscular component is provided by the pelvic diaphragm, which supports the uterus, and the components of the levator ani, especially the pubovaginalis, right? This pubovaginalis will narrow the hiatus urogenitalis. So if there's some injury to this, then what can happen? Yes, that opening can become wide, and that can cause descent of the uterus into the vagina, leading to uterine prolapse, isn't it? And then again, another important component, the puborectal sling. So this puborectal sling, it goes behind the anorectal junction and pulls forward the anorectal junction. Okay, over this, the posterior vaginal wall, it sort of leans over. So the forward curvature of the anorectal junction, it forms a support for the posterior wall of vagina. So if there's some injury to the puborectal sling, then the support for the posterior vaginal wall is lost. That again can favor uterine descent into the vagina. And then again, the perineal body, yes, that maintains the integrity of the perineum. Any injury to it can again predispose to uterine prolapse. The ligament support, yes, of course, they play a major role. The Mackenrodt's ligament, what are its other name? The transverse cervical ligament, the cardinal ligament, which is responsible for holding the cervix in the midline, median position. And then again, the round ligament, the forward pull of the round ligament, the backward pull of the uterosacral ligament is responsible for maintaining the angle of antiversion and antiflexion. Okay, when the uterus is antiverted, there is less chance of prolapse. Which of the muscles make the pelvic diaphragm, right? So the iliococcygeus, the pubococcygeus, they contribute to the pelvic diaphragm. The pelvic diaphragm, it is made up of levator ani and ischio-coccygeus, also called the coccygeus. This levator ani has two components, pubococcygeus and iliococcygeus, right? Remember, the hip bone has three parts, the ilium, the ischium, and the pubis, right? So can you identify here? This is the pubis, right? And over here will be the ilium, and this is the ischial spine. Over here is the sacrum, right? These are the fibers of pubococcygeus, from the pubis going backwards to the coccyx. And here, these are the fibers of iliococcygeus. The pubococcygeus and iliococcygeus together, they form the levator ani. And these are the fibers of ischio-coccygeus or just coccygeus. So the levator ani along with the coccygeus together form the pelvic diaphragm that supports the pelvic viscera here. So can you appreciate? This is the urethra, the vagina, and the rectum going to continue as the anal canal. Yes, definitely we should know about the pudendal nerve. Very important, right? The pudendal nerve is the nerve of the perineum. It comes from the sacral plexus and the ventral rami of S2, S3 and S4. So it is actually given off in the pelvic cavity, right? From the pelvic cavity, it passes through the greater sciatic foramen to reach the gluteal region. We see the pudendal nerve first over the gluteal region here, okay? And this is the ischial spine. We see it over the dorsal surface of the ischial spine in the gluteal region. And then from here, it passes through the lesser sciatic foramen to enter the perineum. And what do you get to see in the perineum? In the ischioanal fossa. In the lateral wall of the ischioanal fossa over the pudendal canal. The other name for pudendal canal is Alcock's canal. Do you remember? So over here, I'm sure you're familiar with this image, right? In our comprehensive session, yes, we have did in detail ischioanal fossa. So this is the anal canal. On either side of the anal canal, we have the ischioanal fossa. And over the lateral wall, here is the pudendal canal. And in the pudendal canal, we get to see the pudendal nerve, right? What are the branches coming from the pudendal nerve? Again, very important. So the very first branch is the inferior rectal nerve. This is given off while the pudendal nerve is there in the ischioanal fossa. This inferior rectal nerve, it traverses the ischioanal fossa, the fat in the ischioanal fossa, to reach the anal canal. And what does it supply? It supplies the external anal sphincter, right? So here is the anus. It supplies the external anal sphincter, the perianal skin, and the part of the anal canal below the pectinate line. In female, the lower 2.5 centimeter of vagina. It is going to be innervated by inferior rectal nerve. And then this pudendal nerve, it will give a perineal branch and a dorsal branch. This perineal branch will further divide into a superficial and deep branch. The superficial branch, it is sensory. Deep branch is muscular. The superficial sensory branch, those are the posterior scrotal or labial nerves which supply the skin over the posterior two-thirds of the scrotum or the labium majus. Okay? And again, the muscular branch that goes to supply the muscles of both the superficial perineal pouch and the deep perineal pouch. And then the dorsal branch of the pudendal nerve. Okay? The dorsal nerve of the penis, it supplies the skin of the penis, the prepuce and glans penis. Over the female, the dorsal nerve of clitoris, it supplies the clitoris. So the inferior rectal nerve, the perineal branch dividing into superficial and deep, and then the dorsal nerve. So these are the branches of the pudendal nerve. And you can see, yes, it's going to supply all this area over the perineum. So what happens during normal delivery when the fetal head is coming out through the vaginal opening and the stretching of the skin there causing pain, that can be relieved by a pudendal nerve block, right? And the best area is to approach the pudendal nerve is right over the ischial spine. It is related to the dorsal surface of the ischial spine. Now, the internal pudendal artery. So, this internal pudendal artery is one of the terminal branch coming from the anterior division of internal iliac artery. The course of this internal pudendal artery is similar to that of the pudendal nerve. So, from the pelvic cavity through the greater sciatic foramen into the gluteal region, over the dorsal surface of the ischial spine, and then through the lesser sciatic foramen, reaches the pudendal canal in the lateral wall of ischioanal fossa. What are the branches coming from it? The inferior rectal artery. So this artery that you see here, traversing the ischioanal fossa, this is the inferior rectal artery. And then the perineal branch coming from the internal pudendal artery that will further divide into transverse perineal artery and posterior scrotal or labial arteries. Apart from that, remember the cross section of the penis. Here is one by one. The dorsal artery of penis, the deep artery of penis, and then the artery to the bulb, the urethral artery. All these are branches of internal pudendal artery, right? So, we have seen that, yes, the region of the perineum, it can be divided into two triangles. Yes, This is the anal triangle, and in front we have the urogenital triangle. Yes. And in the anal triangle, so this is the anus, right? On either side of the anus, we have learned that this space is the ischioanal fossa. So, what are the key points that you should definitely remember in relation to ischioanal fossa? Shall we brush it up? Okay. So, the ischioanal fossa that you see here, it is located on either side of the anal canal. What is the purpose of it? It allows expansion of the anal canal, yes, during defecation, right? And over the lateral wall of this ischioanal fossa, we saw the pudendal canal, which is also called the Alcock's canal. What does it contain? It has the artery, vein and nerve. So it is the internal pudendal artery, the internal pudendal vein and the pudendal nerve. But yes, you see sort of two nerves, right? So the pudendal nerve has already divided. So the arrangement of the structures in the pudendal canal from above below will be. This one here is the dorsal nerve of penis or clitoris. And this one here is the internal pudendal artery. And here the internal pudendal vein. Right? And this is the perineal branch of the pudendal nerve. So this is the arrangement of structures in the pudendal canal or Alcock's canal, which lies in the lateral wall of ischioanal fossa. Now, what are the contents of ischioanal fossa? Already in the pudendal canal, we have seen the internal pudendal vessels, right, and the pudendal nerve. Okay, then traversing the ischioanal fossa, we have the inferior rectal nerve and inferior rectal vessels. Apart from that, we have the posterior scrotal or labial vessels, posterior scrotal or labial nerves. And then again, from the sacral plexus, perineal branch of SO, perforating branches of S2 and S3. Okay, they are also present in the ischioanal fossa. And all the yellow that you see here is the fat. So, the clinical importance of ischioanal fossa is it's prone for development of abscess. The fat that is present here is more of fibrous nature and there is poor blood supply. So, it's more prone for abscess formation. And if the abscess involves the perianal space, because of the septa traversing it, dividing into tight compartment, it leads to severe pain, right? And if the abscess is over the ischioanal space, yes, it can form a fistula into the anal canal. Another important thing is that, yes, the ischioanal space of one side, it communicates with the ischioanal space of the other side behind the rectum anal canal. So the abscess formed on one side, it can travel to the other side, forming a horseshoe-shaped abscess. Yes, now moving on to the urogenital triangle. So what are the layers as we dissect through? So this is the skin. Then you can appreciate the fatty layer. The membranous layer over here, we are going to call it as the Colles fascia. What is present above the Colles fascia, the muscle that you see here, that area is the superficial perineal pouch. And this membranous layer that you see here is the perineal membrane, which is also called as the inferior fascia of the urogenital diaphragm. Above that, okay, above the perineal membrane, we'll get to see the deep perineal pouch. So the demarcation between the deep perineal pouch above and the superficial perineal pouch below is the perineal membrane, isn't it? So if this is the perineal membrane, above it, it is going to be the deep perineal pouch. And below it is the superficial perineal pouch. Let us now do the boundaries and the contents of both the perineal pouches. So here, I'll mark the perineal membrane. So what I show here in pink color, that is the perineal membrane or the inferior fascia of the urogenital diaphragm. And here, what I show here in green color, that is the superior fascia of the urogenital diaphragm. The deep perineal pouch is bounded above by the superior fascia of urogenital diaphragm and below by the inferior fascia of urogenital diaphragm or the perineal membrane. It is closed on all sides, right? And this deep perineal pouch is going to be traversed by the urethra. In the female, the membrane is urethra in the male. What are the contents of this deep perineal pouch? So here this is the membranous urethra. Just next to it, this muscle, skeletal muscle fibers that you see here is the sphincter urethrae, right? And then more lateral to it, these will be the fibers of deep transverse perineum. So the two muscles in the deep perineal pouch is sphincter urethrae and deep transverse perineum. What are the vessels that you'll encounter in the deep perineal pouch? Along the pubic arch, the internal pudendal artery, which is going to divide into the dorsal artery, the deep artery, and the artery to the bulb, right? And what about the nerves? The dorsal nerve of penis or clitoris. And the other structures in the deep perineal pouch, as I told you, the membranous urethra. On either side of the membranous urethra, these are the bulbourethral glands or the Cowper's glands, right? And yeah, in the female, the vagina behind the urethra. These are the contents of the deep perineal pouch. Do remember the two muscles, the sphincter urethrae and the deep transverse perineum, and also the bulbourethral glands present on either side of the membranous urethra. Now let us move on to the superficial perineal pouch. So we know that it is situated below the perineal membrane, isn't it? Below the inferior fascia of the urogenital diaphragm. And this is the membranous fascia of the perineum, the Colles fascia. So this area is the superficial perineal pouch. It is bounded above by the perineal membrane, below by the Colles fascia, on either side by the ischiopubic ramus. Behind, it is closed by the fusion of this Colles fascia with the perineal membrane, the posterior aspect of the perineal membrane, but it is open in the front. I'll show you an image here. So over here, so this is the membranous urethra, right? Yeah. And this is the perineal membrane. This is superior fascia of urogenital diaphragm. Over here, this is the Colles fascia that fuses with the posterior aspect of the perineal membrane. And what you see here is the superficial perineal pouch. This is the area of deep perineal pouch. Remember, while doing anterior abdominal wall, yes, we have learned that there is no deep fascia, but a point below the umbilicus, the superficial fascia divides into a fatty layer, fascia camper, and a deep membranous layer, fascia scarpa. So this is the Scarpa's fascia, right? This membranous layer, the Scarpa's fascia, if we trace it further down, it becomes continuous with the fascia of the penis and then with the dartos of the scrotum and then with the Colles fascia, right? So this is very, very important. Why so? What you see here is the external oblique muscle and aponeurosis, right? This space that you see between the Scarpa's fascia and the external oblique that lies beneath it, it is called the superficial inguinal space. This space, it becomes continuous with the space around the penis, around the scrotum, and also with the superficial perineal pouch. Okay, so if there's going to be a rupture of the bulbar urethra, the urine can extravasate into the superficial perineal pouch. From there, it can move on around the scrotum, around the penis, into the lower part of the anterior abdominal wall. But because of the fusion of the Colles fascia to the posterior aspect of the perineal membrane, it cannot move on to the deep perineal pouch. Can I repeat that again for you? Okay. So here, rupture of the bulbar urethra, the urine from the bulbar urethra, right, it will enter the superficial perineal pouch, but it will not go into the deep perineal pouch. But it can collect around the scrotum, around the penis, and extend into the lower part of the anterior abdominal wall because of the continuity of the Scarpa's fascia, right? Now let us learn about the contents of the superficial perineal pouch. So the muscles that are situated here, it includes the ischiocavernosus on either side, the bulbospongiosus in the middle, and also a pair of superficial transverse perineum. And the vessels that we get to see here will be the posterior scrotal or labial vessels and the transverse perineal vessels. And the nerves again, posterior scrotal or labial nerves and the perineal branch of posterior femoral cutaneous nerve. Apart from this, the crus penis or clitoris, in the male, the bulb of the penis traversed by the spongy urethra, and in the female, the urethra, behind that the vaginal opening, and then the bulb of the vestibule, and more importantly, the greater vestibular glands. So remember, the bulbourethral glands in the male, the Cowper's glands, were present in the deep perineal pouch. The greater vestibular glands, they are present in the superficial perineal pouch in female. A 32-year-old male patient with history of motor vehicle accident has presented to casualty with pelvic fracture. His vitals are stable, but he is unable to pass urine. On examination, he has bled at the penile meatus. A retrograde urethrogram has been performed as shown below. What is the most likely site of urethral injury? The main clue here is this term, pelvic fracture. Unable to pass urine. Right. So, this classically, yes, it associates it to posterior urethral injury, rupture of the membranous urethra. So we know the parts of the male urethra, right? The preprostatic, the prostatic, and then the membranous urethra. The spongy urethra further divided into bulbar urethra and penile urethra. Okay. So the prostatic urethra and membranous urethra, we classify them as posterior urethra. The bulbar urethra and penile urethra, we classify them as anterior urethra. Posterior urethral injuries are always linked to or associated with pelvic fractures. Yes. And it presents with a triad of symptoms: inability to urinate, blood at the urethral meatus, and palpably full bladder. So when there is rupture of membranous urethra, I've told you, the urine will collect in the deep perineal pouch. Rupture of membranous urethra. Urine will extravasate into the deep perineal pouch, right? Anterior urethral injuries involving the bulbar urethra, penile urethra, most commonly due to straddle injuries. Also, iatrogenic injuries and penetrating injury. If in case the buccal fascia is intact, then there will be edema, discoloration confined to the penile shaft. But do you remember, as we have seen, traced it, the continuity of the Scarpa's fascia, right, around the penis, around the scrotum and into the superficial perineal pouch. So this can extend into the walls of the scrotum also. Okay. When there's a rupture of the bulbar urethra, the urine, yes, from the bulbar urethra, it is going to extravasate into the superficial perineal pouch. And from there, around the walls of the scrotum, around the penis. And then remember the space we saw between the fascia scarpa and the external oblique? Into that part, lower part of the anterior abdominal wall. In bulbar urethral injury, anterior urethral injury. Yes, let us learn about the perineal body. Where is it situated? So this is the anus. In front of the anus, this is the perineal body. It is the central tendon of the perineum into which most of the perineal muscles insert. It is a pyramidal structure, fibromuscular nodular structure. And the apex of the pyramid, it receives the rectovesical fascia, right? What are the muscles inserting into this perineal body over here? So, it is arranged as a deep stratum, intermediate stratum and the superficial stratum. Over the deep stratum, the fibers of levator ani. And in the deep stratum, the deep part of the external anal sphincter and the two muscles present in the deep perineal pouch, what are they? The sphincter urethrae and deep transverse perineum. And in the superficial stratum, what are the muscles in the superficial perineal pouch? Over here will be the bulbospongiosus, and this is the superficial transverse perineum, right? And yes, the superficial part of the external anal sphincter. All these, yes, they have a contribution sent to the perineal body, which maintains the integrity of the perineum. So accidentally, yes, if it is going to get injured, then that will weaken the perineum and can lead to descent of the pelvic viscera. So what is this procedure we are doing here? During normal vaginal delivery, yes, a well-planned cut, episiotomy, is done to widen the vaginal opening to prevent injury to the perineal body, right? To prevent accidental injury to the perineal body, we cut the vaginal wall to facilitate the delivery of the baby's head, right? Yeah. So because if the perineal body is torn, as I told you, it will, yes, weaken the perineum and lead to prolapse of the pelvic viscera. In this session, we have tried to recollect, revise the key points related to anterior abdominal wall, posterior abdominal wall, the blood vessels of GIT, the viscera related to alimentary tract, right, the extrahepatic biliary apparatus, the peritoneal cavity, also about kidney, ureter, urinary bladder, and then the male and female genital system, the pelvis, and the perineum, isn't it? So, all the key points and the concepts we have tried to revise. Whatever way the question is put, whether it's an image-based question, MCQ or a short note, Please try to memorize all these points and reproduce it. Hope it was useful. Thank you. Happy learning.